79 to 89%. This prevalence is interestingly high and is higher than the one reported among the population of autism spectrum disorders, which is 46.8%. The digestive symptoms include feeding difficulties in 52 to 61% of cases, functional constipation in 30 to 47% of cases, gastroesophageal reflux disease with an unknown prevalence, and repeated vomiting, sometimes falling within the nosological framework of cyclic vomiting syndrome, with a surprisingly high prevalence ranging from 21 to 42%. Concerning cyclic vomiting syndrome, and quickly because I trust you'll have a full presentation focused on this syndrome tomorrow morning, its prevalence is estimated at 1.9% among children. This symptoms is characterized by acute, stereotyped, and recurrent episodes of intense nausea and vomiting. Symptoms evolve in period recurring cyclically, and each episode lasts from a few hours to a few days, and there is a return to baseline between each episode. So in front of this high prevalence of digestive symptoms and the surprisingly high prevalence of cyclic vomiting syndrome, and because the prevalences we talked about are based on only 3 main articles published in literature, we wanted to conduct a study whose objectives were to describe gastrointestinal disorders presented by patients suffering from White Sutton syndrome and repeated vomiting and CVS in particular. We wanted also to calculate the prevalence. In order to meet these objectives, we decided to conduct a participative study, first because it was answering to a repeated request coming from members of the French White Sutton Association. This association is particularly active and represents most of the French patients suffering from White Sutton syndrome. We also know that participative studies in the field of gastrointestinal disorders are not unusual in literature, and it seems to have a good degree of family-physician correlation. So we decided to design a questionnaire which was divided into 5 parts. The first part was general, collecting general data from patients, like their age, their genetic variant, and the main medical and surgical history, for example. The second part was focused on repeated vomiting. We were searching for CVS using ROM4 criteria. We also looked for migraines and abdominal migraines, which are differential diagnosis of CVS using ICHD3 criteria. We wanted to evaluate the impact on quality of life of those repeated vomiting, and we used a visual numeric scale ranging from 0 to 5, 5 corresponding to a major impact on quality of life. We then asked the parents about the management and the evolution of those repeated vomiting. The part 3 was focused on constipation, trying to confirm the diagnosis using ROM4 criteria. We also asked parents the management of the constipation in their children. Part 4 was focused on feeding difficulties, searching their cause. We also asked patients whether nutritional support was required, and if so, what kind of nutritional support, at what age, and for what duration. Lastly, the 5th part was focused on gastroesophageal reflux, searching for extradigestive symptoms. We also asked whether complementary exams were performed, their results, and how the reflux was managed. Once the questionnaire was finalized, we sent it to the French White Sutton Association, who distributed it to its members. After a first reading of the answers to the questionnaire, in case of repeated vomiting or if CVS was suspected, patients or their referring practitioner were contacted again in order to refine the etiological diagnosis. And it was the same in case of missing data. Concerning the general results of our study, 34 patients answered our questionnaire, leading to a response rate of 72%, allowing us to describe 58% of the French patients. The main medical history of our patients were neurodevelopmental in 100% of cases, ophthalmologic in 80% of cases, and gastrointestinal in 60% of cases. We had a majority of truncating genetic variants. Concerning repeated vomiting, all cause confounded, the prevalence was 35%. The cause was migraine in 25% of cases, CVS in 25% of cases, and other causes, including, for instance, gastritis or a side effect of a treatment in 50 cases. If we focus solely on repeated vomiting, excluding CVS, the mean age at symptoms onset was 6.7 years. The quality of life impact was estimated at 4.25 out of 5 by parents. The evolution showed improvement in 67% of cases, stabilization in 22% of cases, and worsening in 11% of cases. 4 patients never benefited from specialized consultation concerning those repeated vomiting, and 2 patients never benefited from any medical consultation concerning those repeated vomiting. If we focus on cyclic vomiting syndrome in our study, the prevalence was 8.8%, corresponding to 3 patients. The mean age at onset was 3.7 years. The quality of life impact was estimated at 5 out of 5 by parents. 1 patient didn't benefit from a specialized consultation. And concerning the evolution of cyclic vomiting syndrome in our study, the first patient became to be symptomatic at the age of 2. He presented with 1 episode of vomiting per month until the age of 6, when symptoms disappeared. This patient was not diagnosed during his symptomatic period and did not benefit from specific treatment. The second patient presents with a severe phenotype of white Sutton syndrome. He began to be symptomatic of vomiting at the age of 4, presenting 1 episode of vomiting per month until the age of 9. At this time, he required parenteral nutrition due in part to the association of vomiting with other digestive symptoms. And the diagnosis of CVS was made at this time, and the specific treatment was began at that moment, leading to an improvement in his symptomatology. Recently, and sadly, his symptoms worsened and he again required parenteral nutrition. The last patient began to be symptomatic at the age of 5, presenting 1 episode of vomiting every 4 months for a period of 15 years, and his symptoms disappeared at the age of 20. This patient benefited from background treatments. Concerning constipation, the prevalence was 35% according to parents. Only 6 patients met the Wormford criteria for functional constipation, decreasing the prevalence to 18%. Among these patients, 4 were treated by polyethylene glycol, 1 followed dietary rule, and 1 was left untreated. Concerning the 6 other patients who did not meet Wormford criteria for functional constipation, 4 were also treated by polyethylene glycol, 2 requiring occasional enemas, and 1 was treated with a combination of osmotic and lubricant laxatives, and 1 was not treated. Concerning feeding difficulties, the prevalence was 29%. Those difficulties were linked to chewing difficulties, swallowing difficulties, reflux, hypersensitivity of the oral region, or allergy to cow's milk proteins, according to parents. 2 patients required transient enteral nutrition, and 1 patient required parenteral nutrition. Concerning reflux, 29% of patients suffered from it according to parents. 4 patients showed extra digestive symptoms of reflux, included repeated ENT infections and/or chronic cough. 5 patients underwent complementary exams. 1 patient underwent pH monitoring and esophagoduodenal transit, showing acid reflux in the context of hiatal hernia. 3 patients underwent esophagoduodenal fibroscopy, showing signs of esophagitis. And the last patient underwent pH monitoring, not showing signs of acid reflux. 1 patient required gastric fundoplication, and 6 patients received proton pump inhibitors. So now let's discuss the results of this study. So we conducted the first study solely focused on gastrointestinal disorders among patients suffering from White Sutton syndrome. We obtained a very satisfying response rate from the members of the French White Sutton Association, allowing us to describe more than half of the patients in France, according to the report from the National Bank of Rare Diseases. The participative nature of this study allowed us to obtain a very detailed description of the digestive phenotype. Concerning the general features of the patients in our studies, it seemed to be similar to those reported in literature, and the prevalence of digestive disorder were in line with previous reports. However, we had less genetic variants with severe clinical impact. Concerning cyclic vomiting syndrome, the prevalence of CVS initially seemed much more lower than the one previously reported in literature. We tried to understand why and carried out a literature review, selecting from PubMed all articles reported cases of White Sutton syndrome, in which information on the presence or absence of gastrointestinal disorders was present. We selected 19 articles reporting 84 patients. Of these, information on the presence of vomiting was available for 81 patients. And overall, the prevalence of CVS was 14.8%, closer to our own results. We also suspected that the fact that we had less genetic variants with severe clinical impact could explain a part of this difference. The characteristic of CVS in the White Sutton patients seems to be similar to those of CVS in general population. We also tried to see if there was a phenotype-genotype correlation. In this figure, which is a schematic representation of the POD protein, we placed above the variations of our patients, with in black the patients suffering from CVS, and below we put the genetic variants of patients suffering from CVS in literature. They look to be close on the protein, but they do not interest a particular protein domain, and they are not localized in the same exon of the gene. Therefore, with those data alone, we were not able to hypothesize that a phenotype-genotype correlation does exist. Concerning repeated vomiting, this study allowed us to report other causes than CVS in White Sutton patients, which had never been the case before. The etiological diagnosis of repeated vomiting in this patient seemed difficult due to the frequent association of digestive symptoms in the same patient, and because of the characteristic of patients suffering from neurodevelopmental disorders who can have difficulties to express their symptoms, their pain, and to localize it, for instance. This was reported by several parents when answering our questionnaire. We were therefore quite surprised to see that some patients did not consult any physician concerning those repeated vomitings. We showed that they, however, had a strong impact on quality of life, and we believe that there is a need to improve the management of these patients in order to improve their quality of life. Concerning constipation, its prevalence according to ROM4 criteria according to ROM4 criteria was inferior to the one in literature, but the fact that 85% of patients not answering ROM4 criteria were still treated led us to suppose that there are some difficulties to apply this criteria among this population, which has already been pointed out several times in ASD literature. Concerning feeding difficulty, the prevalence was also inferior to the one previously reported. We suspected that the absence of clear definition of feeding difficulties could explain this difference, and also that memorization bias could play a role. However, the fact that the prevalence of enteral nutrition was also inferior to the one previously reported led us to suspect that once again the less genetic variant with severe impact could explain this difference. Finally, concerning gastroesophageal reflux, for the first time we report here a prevalence which is superior to the one found in pediatric population. It could be a bit overestimated because it's not easy for parents to distinguish a physiologic reflux to a pathologic one. However, it contributes to feeding difficulties and is a differential diagnosis of CVS and should not be overlooked. In conclusion, we realized the first study focused solely on gastrointestinal difficulties, and its participative nature allowed us to make a very comprehensive phenotypic description of those difficulties. We found an important prevalence of CVS, even if inferior to the one previously reported, and show that it has a strong impact on quality of life and that there is a need to improve the management of the patients. We also find that there is a need for further studies in order to seek for a phenotype-genotype correlation that could help minimize diagnosis delay for CVS, for example, and improve the management of the patients and the quality of life. So I would like to thank every member of the French White Sutton Association for their participation in this study, and the president of this association who helped us at every step of the study. And thank you for your attention. And here is our mail address if you have any question. I don't know if we have time for live questions.
Do I? No.
Not busy.
Have any questions in the audience?
Not audible here, only there. Okay. I relay the question. So if there is any question, we need to. We're asking for question here, so 1 sec.
Okay.
We got a question. Okay. It's a lot. Test. Only her. Okay. Okay. Can you explain? I'm trying to put myself in a parent's shoe, so I'm just a grandma.
Okay.
Trying to put myself in a parent's shoes. Can you explain to me? There's a lot of data that you presented to us. So could you explain to the audience how you came up with, like, for example, the 3.7 year age group, because as a parent, I would almost want to see the actual data between age group so that I know maybe what to expect at stages of development of my child throughout their life.
Well, in fact, what I told is that the mean age at onset of symptoms of vomiting in the cyclic vomiting syndrome group was 3.7 years, which is along the data in general population for cyclic vomiting syndrome. And it means that compared to other causes of repeated vomiting, the vomiting appears early in cyclic vomiting syndrome compared to other causes of repeated vomiting. I'm not sure if it's clear.
Is that an age group between 1 to 10, and then you're taking all the participants in your study and making an average based off of just age data? Or is that, like I said, broken down by age group? Like 1 to 3-year-old or 4 to 6-year-old?
In fact, I asked parents at what age the vomiting began, and with the answers, I calculate a mean age at symptoms onset.
Thank you so much for your time and presenting with us today. We appreciate you.
Thank you.